blue button.
Press it. Right, now I can talk. Okay, ladies and gentlemen, good afternoon to you, and a warm welcome from a magnificent Cape Town. This last weekend we were rained out, but now there's not a cloud in the sky, and we have the great advantage of having Dr. Renardo Lourens over here, and he's going to be speaking about surgical update on placenta praevia and placenta accreta spectrum cases. Now, Renardo is something of a expert in this particular topic. I sent all my placenta accretas to him, and it's wonderful to have him over here as a speaker this afternoon and a great resource to have as a backup. Dr. Renardo Lourens, as you can see, is a urogynecologist and an obstetrician of note at the Mediclinic in Panorama. He's been very kind and generous with his time here this afternoon, and he says that if you have any pressing questions, he'd be very happy if you interrupted. Our co-host this afternoon is Professor Stephen Jeffrey. Stephen, welcome.
Thank you very much, Pete. And of course, very good to have Renardo here. We know each other very well. He's also a urogynecologist by training and also has a high-volume urogynecology practice. So good background, I think, for these cases.
Excellent. Yeah. So, we also have Chris over here. Thank you very much, Chris, our technical supporter. And the Pelvic Floor Foundation is the sponsor. The Pelvic Floor Foundation of South Africa is the sponsor this afternoon. We won't waste any more of your time, Renardo, and thank you very much for letting the people interrupt and having a few minutes at the end to ask questions. We have a very large turnout here this afternoon, Steve, and it gives me great pleasure and great anticipation to having Renardo, I could think of nobody better than Renardo in addressing this topic. So Renardo, would you mind sharing your screen, please?
Thank
you, it's shared. We can see now.
Can you share it? Can you see my screen?
I can see your screen.
And we can see your slides. So
we can see you as well.
Well, thank you very much to Steve and Peter for the invitation. I really appreciate it. And thank you for the Pelvic Floor Foundation that's setting up such a nice platform for us to share information, learn from each other. And I think it's a wonderful thing that you're driving here. And thank you also. We'll see later something from FIGO, and thank you for your efforts in getting FIGO underway in our beautiful country. So without much further ado, thank you for the opportunity to speak on this very heavy subject. And when the hand was dealt to me, I thought as a bit of a heavy burden onto me, because it's quite a lot said, quite a bit on sureties, but let's see how it goes. So just the agenda we're following is going to be talk about the definitions, the background, screening, diagnosis, management options. And let's start off with the placenta accreta spectrum variety, but normally starts with the placenta praevia. And once we have a partial or complete covering of the cervical loss by the placenta, this already increases your risk for a placenta accreta spectrum, going from just a placenta praevia right through to placenta accreta. Now that's the FIGO classification, and if we look at it, there are mainly three grades, and it's almost following the same sort of thing as for a obstetric sphincter anal injury, grade 1, 2, and then the 3A, B, and C. And if we look at accreta, it's mainly a clinical diagnosis. So you've delivered the placenta, a baby. You've given your oxytocin, you've done gentle contraction, the placenta is not coming. And that for that manual removal in theatre that you are setting yourself up for, this is the things that start need to go through your head. Is there maybe the placenta and accreta? And if you send the placenta away for histology, asking if it's an accreta, you'll never get an answer back, because you need to have myometral tissue to actually make the diagnosis of an accreta. So placental tissue alone will not give you the diagnosis. Grade 2 is of an increta. Normally on laparotomy, you'll see a bulge, there's hypervascularity. It's not going through the serosa. And the uterus indents with traction on the cord. And grade 3, then this is the real worrisome one, is where there's a precreta, it's limited to the serosa, there's bladder invasion, and then the most feared of all, if there are other pelvic tissues as well. Now, why is this so important? Well, just due to the increase in cesarean section rate, there's been noted an increased risk in the maternal morbidity and mortality, mainly driven by hemorrhage. These women are more likely to have an hysterectomy and longer hospital stays. So if we just look at this table, it was published in 2006, you can see by the third cesarean section, or by the fourth pregnancy, and if you have already had 3 cesarean sections, your risk for placenta accreta is 2.13%. And that goes up almost 4 times from the third to the fourth pregnancy. But if we look at the third pregnancy, here at the 40% rate, then if you have a placenta accreta, your chances of having a placenta accreta, if there's a praevia, is about 40%. Now that's significant. And if by your fourth pregnancy you have a cesarean section, not even, well, this is including women with or without the placenta praevia, your risk for a hysterectomy is 2.4%. And if you go to your sixth pregnancy after 5 Caesars, your risk is almost a 9 to 10% risk of having a hysterectomy. This is considerable. So obviously there needs to be some form of screening and diagnosis. And obviously we always have to preempt things. And there are many risk factors for an accreta. And these include a previous cesarean section, previous curettage for a miscarriage, IVF pregnancies, advanced maternal age, a previous adherent placenta or there was a manual removal, multiparity, a placenta praevia with no previous cesarean section. You have a 3% incidence of a placenta accreta spectrum. And there is some studies looking at an increase in biomarkers, especially PAP-A and AFP. Now, if we look at your PAP-A, which is done quite a bit, and if it goes above 2.63 to multiples of the median, your risk for a placenta praevia accreta increases significantly. However, just doing the test alone and predicting the risk for placenta accreta is actually quite low. And not low, but it's not so accurate. And alpha-fetoprotein, if you have a placenta praevia, it is normally increased. However, trying to predict by just doing an alpha-fetoprotein does not seem to have that much of a predictive value at present. So the screening and diagnosis is normally a high index of suspicion. If there's a previous cesarean section with a presence of a placenta praevia, one should already think about, is there a risk for placenta accreta spectrum? All women with a previous cesarean section and low-lying anterior placenta praevia, it's a placenta less than 2 centimeters from the internal os after 16 weeks, should be referred for an ultrasound analysis. And this is as per SASOG guidelines. These SASOG guidelines was mainly based on the American College guidelines. So ultrasound is definitely our first line in diagnosis. But once we have made the diagnosis of a placenta praevia and we start thinking about an accreta, or we're looking further towards a placenta increta, MRI is really a small role to play. But once you start thinking about a percreta, increta, percreta, especially for the into the bladder and the division between the bladder and the lower segment, this can be helpful, and especially involvement of the ureters. But other than that, just making a diagnosis of a placenta accreta on MRI alone is not really helpful in terms of the final outcomes. So what are the things that we look at the second trimester? Well, you look at the loss of the normal hyperechoic zone between the placenta and the myometrium. There's normally a decreased retroplacental myometrial thickness of less than 1 millimeter. And this can be really difficult to see, but in some cases, especially with the anterior placentas, it's not that difficult. And many of us listening to this, you know, we do a lot of scans, and it shouldn't be too difficult to look at these interfaces. There's normally a thinning or a disruption of the uterine and serosa bladder interface, and then there's extension of the placenta into the myometrium. So you lose that nice smooth lines in between the myometrium the placenta. And when that starts happening, the alarm bell should start going off. It could also be a multiple vascular lacunae within the placenta, and this is sometimes a very overlooked a sign. There's diffuse or turbulent lacunar flow, especially between the bladder and the anterior serosa of the lower segment. There could be increased subplacental vascularity, gaps in the myometrial blood flow, and then dilated vessels over the peripheral subplacental zone. So if we have to pick two things that could tell us or lead us into the direction of a placenta accreta, and sometimes missed, especially in first-time pregnancies, no previous cesarean sections, maybe just previous curettage, it is lacunae. And then in the patients with previous cesarean sections with a low anterior placenta turbulent flow. So the ultrasound prenatal identification, according to a systematic review with a positive predictor value of up to 90%, and that's significant. So here we can just see a picture of what a placental lacunae looks like. Not very impressive, no big legs, but if you start seeing those, some people also call it placental legs, you should see the alarm bells go off and really red lights. Because the biggest problem with managing these conditions is when it hits you unexpectedly. And I think that is what the world and placenta accreta spectrum disorder or condition wants to highlight is early screening, diagnosis, and then referral to an MDT center. Now,
Renardo, sorry, can I just interrupt you? So, you know, the chance of missing 1 in 10 of these on ultrasound has quite profound consequences. I don't know. I mean, I think Bruce Howard is quite keen for MRIs in these kind of patients who, you know, I don't know. What are your thoughts on that? Being a little bit more, you know, I think it's obviously quite costly, but do you think that you know, if an ultrasound is excluded, you know, a accreta especially, do you think, are you comfortable with that, or what are your thoughts?
I think I'm comfortable with that. Steve, if there are no subtle signs, it's all these little subtle signs that need to be picked up. And I think with excellent sonographers and fetal maternal specialists in Cape Town who can focus in and zoom in on these things, you know, they see and look at placentas way more than the general radiologist or even MRI radiologist. So I think just based on the fact that there's a different sort of perspective where they come from when they look at these things. And if you as a general gynecologist or obstetrician look at it and there are a few alarm bells going off or red lights, I would first refer to one of our esteemed colleagues and let them first have a look before we do an MRI, because the MRI is expensive. And it cannot then say yes it is or yes it isn't. But even if you have and I think this is where it is important, rather treat a placenta accreta spectrum and then fall back and it is not. That's the better way of going about it. Then get your foot into an unplanned hysterectomy with massive hemorrhage. And that's what needs to be prevented.
Thanks.
So I think the MDT center, and especially in private practice, let's be open about it. There's not extra remuneration. You have to work in a team of other obstetricians that's happy to or skilled in dissection of the pelvic side wall. Even if you have an oncologist nearby, people who are used to urethrolysis. And if it's not done on a regular basis and pelvic wall dissection, then really one should try and find a colleague to sort of help you out with that. But I think the obstetrician plays the pivotal role with the maternal fetal specialist. The anaesthetist obviously has to play a big role, and unfortunately, anaesthetist works in groups. But you need to have 1 or 2 anestheters that you need to say, listen, if you're away for this weekend, can we fall back on that person? And this is where the real dilemma comes about with the. And there's no place that you have an MDT center, but you're not available 24/7. So it really plays a big role on everybody involved to be available. It doesn't help you just have one vascular surgeon in your hospital who's only on call like every second weekend. But what happens if that patient then comes in? A urologist our urologists are quite skilled, and I think in Cape Town we're blessed with quite good urologists. We have got a good blood bank, but blood is also difficult sometimes to get to a hospital. So make sure that the MDT center that you have, or if you're up to treat this, you don't have to be an MDT center, I guess, but you have to have these people around you, cell saver technologist, the intervention radiologist, maybe a hybrid theater. It's ideal, but necessary. And then obviously physicians dealing with pregnancies on a regular basis, and then the ICU, because these pregnancies ultimately end up in preterm births. So they looking at the literature, and there are many three centers in the world that really publishes a lot on placenta accretum spectrums. The one center is of Michael Balfour, and that's where Henny Lombard is currently in Texas. Then in Dublin, Mike Robson and his team is the other group, and then there's a group in China. And this was a study, and just look at these numbers, because this is a referral center for the whole of Ireland that are referred to Dublin. And actually, one of our colleagues did a obstetric anesthetic stint there for 6 months. So, and he said to me that this is a national referral center. They saw 60 patients between 2006 and 2019, of which they randomized of 32 as a standard care group and 28 in the MDT group. So, and if they look at the MDT group, you can just see that the estimated blood loss is almost a 2 liters difference. And the requirement of blood, the median was 7 units, and in the MDT group was 1 unit. So it clearly shows us that, that working as a team, screening and diagnosis for them to get to a center already plays in their favor. So what about the management? Counseling is very important. The risk of a hysterectomy, women's future fertility perspectives, and also the most important of that is thinking about the first cesarean section. So the first cesarean section is always the most important one. And if that cesarean section happened, and then after that one, and it's for good reason, I always say, then getting a placenta accreta spectrum off that, or a placenta praevia, or whatever it might be, is going to be a sequence of, or as a result of that first cesarean section. So I think the counseling even starts before, one get to a placenta accreta spectrum, and really judge whether the first cesarean section is really necessary. The risk of hysterectomy should be discussed with every patient, and we'll get to it a bit later about conservative and non-conservative approaches. Blood transfusion, the dilemma comes to patients who are Jehovah's Witnesses, etc. It can be managed, but blood transfusion is a big thing. And then injury, and this is injury to the bladder, the blood vessels, all the visceral organs, longer hospital stay, access to the hospital. This is an important point. So if the patient lives anywhere more than 30 minutes to an hour from the hospital, the arrangements need to be made, and towards, from 32 weeks, if they have a placenta, an invasive placenta, anything from 29, 30 weeks should be admitted. If they've never had a risk, or if they never had a bleed, that is sometimes difficult to really assess when to admit these patients. We generally admit patients with a placenta praevia from about 36 weeks, especially if they live far. And with the invasive placenta, it can be even if they have had a bleed from 30 weeks onwards. the risk of mortality is significant. Some studies even quote up to 7%. I quote them normally about 3%. So if we look at the management antenatally,
Renardo, so we've got a question over here.
I'm
You mentioned
Yeah.
in the previous slide Jehovah's Witnesses, and you said they can be managed in the context of blood transfusions. What do you
Yeah.
mean by that, if there is the question? How
Yeah,
can
so
they be managed?
so we'll come to that
Are
a
you going
little
to
bit
come?
later, but that's
Okay.
that's a very, very good question. So we're going to run through a lot of, maybe just say, we're going to run through a lot of stuff, and then we're going to look in depth so we can just get a picture of where it all fits in, and then we'll zoom in on all the different scenarios. So if we look at the management antenatally more than a day prior, this is where it comes to with the Jehovah's Witness. You must optimize the hemoglobin and the iron. Even if the hemoglobin is not an indication of iron, and ferritin is. And if you have a ferritin of less than 50, 50 and more is normal in pregnancy. Between 30 and 50 is mildly non-anemic iron deficiency. And if you have a count less than 30, you should start supplementing. There's a recent article, and I'd just like to stand still here for a little bit. We all of the mother, but what about the fetus? And if a mother has an HP of less than 10 with a ferritin of between 10 and 30, that baby is already decompensating. And there's 25 years of data now of the importance of iron supplementation for the fetus. So iron supplementation, whether it is oral or IV, needs to be looked at and do. If the ferritin for the placenta spectrum, if the ferritin is less than 30, do a full iron study and work up that woman. So especially for the Jehovah's Witnesses, speak to the renal physicians. They're skilled in using EPO, erythropoietin. And this is where one can really also, push the hemoglobin up. And especially with the dilution phase of pregnancy, this is where EPO can really be of value. Decide on the timing of delivery.
Wouldn't you just, Renardo, sorry to bother, wouldn't you just go straight for an IV? I mean, just really pushing it up quickly, just, I mean,
Yeah, very good point. So I think a good time when should one test your iron levels? Well, some people say at diagnosis of pregnancy, and then again at 24 weeks. Some people say do it again at 16 weeks, but really around about 24 weeks, it seems to be a good time then to start looking at your ferritin levels. And then there should be enough time for an iron that is between 10 and 20 and 30, or even 20 and 30 with a normal hemoglobin of more than 11.5, 12. There should be enough time with the new sucrosomal irons to up the iron. If it is less than that, and if you only do your iron count or your ferritin count after 28 weeks, there is not enough time, and then definitely an iron is indicated. It will also, in this scenario, will depend on your spectrum of placenta accreta that one has. So I think one also has to individualize a little bit, but generally be aggressive on the iron, especially in this scenario of placenta accreta spectrum. So good question. Thank you, Pete. Stephen. Decide on the timing of delivery. If accreta, one can wait up to 37 weeks. If there's an invasive placenta, deliver at 34 weeks. The last thing that you want is to avoid spontaneous labor. And if there's any bleeding, a woman should come to hospital and be evaluated for admission or not. I normally have a very low threshold in admission for these patients, and then also obviously individualized care. With a placenta praevia that's low-lying or covering the os, especially the ones that's partially covering, completely covering the os, and they bleed, living 10 minutes away or 30 minutes away from the hospital is too far sometimes. So, but then what about the doctors? And I always tell the patients, get in time, that getting the patient to the hospital and the doctors is easier than just getting the doctors to the hospital. So the day before, prior to the surgery, you have your cell saver booked, your team informed, see who's on call, see who is available, and never just have one person on, the one urologist or one vascular surgeon or one interventional radiologist. You know, people also have their sort of own times, but sort of the kingpin of the delivery of the team member or the team captain, if I can say that, you know, sort of need to get this all together. ICU bed is very important. And ICU bed mainly, hopefully closely to the NICU, so that if the baby is born at a time where breastfeeding can happen, so that milk, so these little things need to be thought about. Blood ordered, at least 4 units of red blood cells, also depends on the vicinity. Tranexamic acid, some start giving it high doses, 1.5 grams at the time of the start of the anesthetic before cutting. Recombinant factor 7 cryoprecipitate, and the next point is the most important, FDP instead of FFPs. These are freeze-dried clotting factors that's available in most hospitals, and it's given at a dose of 15 ml per kg. And once FFPs are thawed, they cannot be used. And sometimes getting them in time to the hospital or thinking that you need them. So especially if we start giving patients emergency blood, high volumes of blood that you did not expect, waiting for the FFPs to also arrive, then thawed, and then be given. FDPs are really, it has changed the game.
Renardo, how many FDP bottles do you have on standby in your labor ward?
In our emergency trolley, there are none. But we've got a heart unit. We've got a heart unit, and in our heart unit there are many. So it's to do with the pharmacy. So if we need them, if we have a patient with placenta accreta spectrum, and we know that we then get them sourced in for availability. But you can't just keep it in a place where it's not going to be used very frequently. So I think that's also important, and that's why I highlight it here as well. It cannot just be, you know, these things do expire and they are quite expensive, and the hospital is not that big. But if we know that we're going to have a patient that's going to come in, then we normally have it available.
We've got in our labor ward theatre, we've got 4 on standby. So all you have to do, if there's massive obstetric hemorrhage, not necessarily placenta previa or spectrum, we just give it very liberally, and it's a real lifesaver, as you say.
So just for those,
but I thought you said on our emergency trolley. So we have in our theatres, but we don't have in our labor ward. Maybe I've misunderstood you there.
No, sorry. No, I mean we've got 4 in our labor ward theatre. That's where they live.
So you're very privileged. We don't have labor ward theatres. We as part of the general theatre, and we have them regularly, but we don't have them in our labor ward on the emergency trolley. No, but definitely they are there. They are available in theatre, and definitely something to be used. I'm glad you used them as well.
Can I just ask, and so this FTPs is it's a blood bank thing, but you can keep it, you don't have to order it.
It's dry. It lives on the shelf, Steve.
Okay.
It's not in a fridge. It lives somewhere there on the shelf.
Okay.
It lives on the shelf. It's easily mixed. It comes as a dry powder. You mix it very easily, quickly. You hook it up to IV. It's really simple. It's effective. And as Pete said, the expiry, you know, there's I think the expiry date is almost a year.
Yeah, it's very long. It lasts very long.
It could be even longer. But yeah, it's really worthwhile. We need to think about FFPs change to FDPs. FDP, just think FDPs. And I think
give it with your blood transfusion, you'll add some FDPs at the same, like you do with an FFP normally.
100%. 100%. Yeah.
What you look for, Pete?
So also plan the abdominal and uterine incision. I think discuss with the patient, you know, if it's a placenta previa and it's a posterior placenta, it's low lying, you know, your risk of bleeding is there. It's possibly less if she hasn't had a previous cesarean section. Your risk is really low, and you might want to go for a fan and steel. But anytime when you think of an accreta or even if there's an invasive placenta, I can't see that one could get away with proper midline incision that just gives you, the worst for a patient is to end up with a T-shaped incision, I think. And most patients that we discuss a midline incision are very amenable to it, and they understand. And they understand it's with really difficult times, then there's a very good reason why we opt for that. You try an incision, try not to cut through the placenta, or do not cut through the placenta. Cut any part, but do not cut through the placenta. And I think this is important, and also plan with ultrasound. And we can't always remember the exact positions of the placenta in the finest detail. And there's nothing wrong with just taking a marker pen and on the skin draw. Yes, it's not where you're going to cut, but it just gives you an idea that when you're in there trying to fix that picture in your mind, almost thinking about anatomy, where's the anatomy, thinking about where's your incision going to be. I think it's important. So intraoperative, we're going to say a little bit more.
So Renardo, sorry to interrupt, Hal, I'm sorry, but I've just got the latest information from our pharmacist, my team pharmacist. A unit that's
also known as ChatGPT.
A unit of FDPs costs 1,100 Rand, and the shelf life is 3 years. So it's worth it. And it's cheaper than FFPs, also considerably cheaper. Yeah.
No, thank you for that info. It's really worthwhile.
Thanks, Renata.
Uterine preserving or versus non-uterine preserving. And I think it's also where we have to change. So what we do in theatre, we put the patient in Lloyd Davis. The anesthetic team normally do 2 large bore IVs. The minimum size is 16 or less, so we like to go for 14 gauge. CVP and then A-line as well. I think an A-line is really important, keeping a close eye on the blood pressure, seeing what's happening, especially if we start to give adrenaline and inotropes. The type of anesthetic, and there's a real discussion. You have to speak with your anaesthetist on the day with what they feel comfortable. We have done combined spinal epidurals, and it has worked well. Some that we had to convert then to general, that's the tricky time. It's normally when you have to convert, you have a lot of blood loss with a drop in blood pressure. And then doing converting them to general, you have a further momentarily decrease in blood pressure. And this is where things can get really dicey. Of the teams in the world, especially the Dublin team, they do most of their cases with combined spinal epidural and have a very small rate of conversion to general anesthetic. There's the anaesthetist gets trained how to talk to the patient, explain to them. It's almost like a verbal analgesia that they give them. What we've also seen is that once the baby is delivered and there's a lot of bleeding, sometimes the dads don't like seeing their wives being put to sleep, or their wives' blood pressure drop and they all of a sudden go pale, and can be quite traumatizing for them. So even speak to the dads whether they want theatre with the delivery or not. And there have been a couple of cases where the dads actually said to us they really shouldn't have been in theatre. It's something that I didn't think of in the beginning, but as we've gone through, I say to them, it cannot be always a very nice scenario, but it's nice to be there for your wife being put to sleep. Once she's been put to sleep, then we'll bring the baby outside once the baby has been delivered. Cell saver. So Peter spoke about cost. Safety. We don't have to worry about the safety of the cell saver anymore. It's safe. Okay. Meconium, it gets filtered. Amniotic fluid, it gets filtered. And when you have the cell saver, you have 2 suctions. You have a suction for delivery, where you suction up most of the amniotic fluid, and if there's meconium. But if there's a little bit coming through, the cell saver will clear it. And then you have your second suction that goes directly to the cell saver. And that's a suction that we want to get on board as soon as the baby has been delivered and most of the amniotic fluid and the meconium is gone.
So sorry, Renardo, sorry, can I just interrupt again? Do you use the cell saver for just your do you have witness cases? Is that just something that you use routinely, or?
Everything. I'll give you an incident yesterday. I did a myomectomy, 5 myomas laparoscopically. Her blood loss was 900 mils, and there was, in the 900 mils, there was 150 mils of saline, because we use saline. That should rather not use ringers, because saline preserves the blood cells. With that, we gave her almost 700 mils back. Her HB dropped from 12.2 to 11.7. So the cell saver for me is, and let's think about cost. The cell saver for the technician and everything costs, I think, between, not I think, 3,800 rands. 1 unit of blood is 3,500 rands. And the blood cost.
How much? How much is a unit of blood?
1,000. That's including your first cross match, your group and save cross match. So if you're going to give 2 units of blood, if you think any procedure, you do an open hysterectomy, and you think you're possibly going to end up with having to give blood back, especially in a patient who's already anemic, but you can't stop her menorrhagia for whatever reason, just go to a cell saver. Cell saver is really the way to, all the medical aids pay for it. And so far, we have never had any troubles, literally never had any troubles. And you give the patient the blood back immediately. It's not like you have to send the blood back to the ward. It's filtered, and normally you have to have a loss of at least about 500 mils. And 500 mils, you can give back about 250, but the more you lose, the more blood incrementally, exponentially you can give back. So the initial washout takes a little bit of time. But I mean, for placenta accretum spectrum disorders, the blood loss is way more than that. So the cell saver really, really helps. So the cost is nothing compared to blood. If you're going to give 2 units of blood, you've paid for your cell saver. So the cell saver is really something to be used, especially in gynecology and obstetrics, more on a regular basis. Calf pumps, that's also helps us because we have the patient in Lloyd Davis position. The legs are up a little bit higher, and then drainage of the venous systems is there, and then obviously the risks increase. So what about cystoscopy and ureteric catheters? So I think a cystoscopy is important if you suspect a accreta, and then ureteric catheters, you have to individualize. If you think it's necessary, it can help you. It has helped us before, but we don't put ureteric catheters in every single patient. Some people would feel that they want to use it, just gives them confidence where the ureters are, especially if there's a lot of blood. They can palpate the ureters, but it doesn't seem to reduce the risk of injury. What about vascular balloon catheters? And I'm just touching on everything shortly, and then we'll look at it in detail a little bit within the next few slides. Vascular balloon catheters is a big hype currently about it in the literature. But the problem is you can't occlude any vessel for more than 20 minutes at a time. Either you're going to get an emboli, you're going to get ischemia, especially in the digits, toes, etc. So the other thing is have 2 assistants. Never just have 1 assistant. We put the patient in Lloyd Davis so someone stands in between the legs. They can hold retractors with 2 hands, so your exposure is much better. 2 people next to each other just doesn't make sense. So we have 3 positions around the patient, and then normally there are 2 scrub sisters, and more people counting swabs and needles as well. Skin incision, we talked about that. What about the uterine incision? Avoid the placenta. Now this is the Texas group has come up with a linear cutting stapler. Now, we all know about the linear cutting stapler, and just keep it sort of on this and as a tag on your ear for a second. We'll get to that now. But do not give a uterotonic. So once the baby is out, do not give a uterotonic. We do not want placental separation. Because if you get placental separation, that's when the big bleed starts happening. If you're going to plan a hysterectomy, don't get placental separation. So blood loss of more than 2 liters is quite normal. If there's a massive hemorrhage, you start having to give 4:1 ratio, red blood cells to FFPs to platelets. And some people even say if you get to more than 4 or 5 units, you do a 1:1:1 ratio. And I think especially in obstetrics, you cannot go wrong. Sometimes to get all the products to theatre, that is the problem. But we spoke to FDPs. So we would give 1 unit of blood, 1 unit of FDP, and then when we get to 4 units of blood, we'll give one a unit of platelets. So we like a 4, 4, and a 1. Check your INR. Try and keep the INR less than 2. The thromboelastogram is really helpful, and especially a anaesthetist working with a thromboelastogram. If the thromboelastogram is close by, it's really of good help. Tells you on the spot what to do with your coagulation. And then tranexamic acid, don't delay in giving it. Just give it at the skin incision and don't play around with the dose. Give 1.5 grams. There will come a time during the surgery sometimes when the blood pressure drops a lot. Then people are up with swabs. Forget the swabs. Just compress the aorta. And that's why a midline incision really makes a difference, and the second assistant. Take the fist, make a fist, and just put it right onto the spine and do a good compression there. You cannot miss the aortas. There's no need for clamps at that time. It just gives time for the blood pressure to up a little bit, the anaesthetist to get ahead of themselves with resuscitation, and also just to give the whole team a bit of a breather, just to say, listen, yeah, and let's see where we are and carry on from there. What I've learned here from a urologist, Dr. Hans Rabe, especially with nephrectomies is a lot of blood loss, and he normally had a cable tie and left here in theatre. And whenever the kidney was bleeding a lot, he would just put like a cable tie. So you can use a big, nice, thick cable tie, and you get ones that you can release as well. So if there's a lot of bleeding all of a sudden from the uterus, you just can't control anything. You can either grab the uterus and really, control bleeding like that, or you can just put a cable tie around everything and just tighten it up. A Foley's catheter works as well. Sometimes just difficult because you can't, once you've tied the Foley's catheter, you can put an artery on it to keep it there, and don't keep it longer for 5 to 10 to 30 minutes, up to 20 minutes. But normally it doesn't stay on for that long. It just gives you time to sort of get ahead of yourselves and do the devascularization. What about uterine artery ligation and clamping? Yes, very important. Try and get to the uterine arteries as soon as you can. And then internal iliac ligation. Now, you don't do that when you have massive blood loss. You must do that before you have massive blood loss. We'll get to that. So bladder cystostomy, sometimes it's necessary to see where you are. There's nothing worse for a patient coming back with a fistula and treating a fistula. So rather know where you are. If you can't see your bladder, if you don't know where you are, you need to get that friable tissue off, do a cystostomy, put your finger in the bladder, and you know exactly where you are for your dissection. And then hysterectomy, try and get the cervix out, because you can still get bleeding from the cervix. And even after the surgery. So try and get the cervix out, but sometimes the supracervical hysterectomy is the way to go. Friable tissue, and then whether to close the uterus or not after your incision before you do the hysterectomy. So what Michael Balford, where Henny Lombard is also now working in the Texas Institute, this is available in most theatres, in all theatres where a surgeon is working. It's called the Enchelon linear stapler. So basically with your incision into the uterus, you're going to want a bloodless entry. And this is where sometimes most of the blood loss occurs. This is the first point where blood loss occurs. And the second point is with the dissection of the bladder. Now, this article is minimizing surgical blood loss at cesarean hysterectomy for placenta praevia with evidence of placenta accreta or accreta. And they have basically described a 5-step process. They do a midline skin access. They do a hysterotomy where they make a small incision, get the finger in between the amniotic membrane and the myometrium. Then you put the first blade of the stapler in, the second blade stapler, it cuts it and it staples it, and it's a dry field. You're going to need about 4 of these. The second step is superior devascularization. The round ligament and the ovarian uterine ligaments needs to be divided. This is the second time when one can get bleeding, but not that much, and it's mostly because of severe pulling or too much pulling on the Spencer wells or the arteries to sort of get into the broad ligament. Use cautery here to get into the broad ligament, and also when opening up the round ligaments, use cautery to go gently down, but stay away from the uterus, because that's the closer that you get to the uterus, the more blood there will be, more bleeding that there will be. The retroperitoneal dissection is obviously the paravesical space that you have to enter. And once you have entered the paravesical space, you have to do that from a lateral entry point to a medial entry point. And once you've done that, you have to work up all your way to the iliac bifurcation. If you're going to tie off the internal iliac artery, this is the time to do it. If you are not sure where it is, then you have to do ureterolysis. It's a tongue tire, and then be sure that your ureter is out of the way. This is a nice picture demonstrating. This is now on the patients. If we look from if we look up towards the head cephalate area there, here is the inferior part, then that's the ureter. This is the common iliac, the internal iliac, the external iliac, and the external iliac vein. And if you're going to tie it off, you don't want to tie it off proximally to the bifurcation. You want to, and the posterior division of the internal iliac. You want to do it more distal. The next step is where the bleeding can really happen, and this is normally a protracted time of venous bleeding that can be encountered, especially with the venous plexus, especially with the increta and the percreta in between the bladder interface and the uterus itself, because this is where most percretas happen. It must be a lateral to a medial dissection. You use methylene blue, 100 to 300 mils, to stent the bladder, see where you are, see if there's any seepage or leakage from the bladder. If there's a percreta with invasive growth into the bladder, I mean, you have to have a urology colleague with you, and then a ureteric stents would have to be done to know where your trigonum is, especially if you have to do a partial cystectomy. But an intentional cystostomy is very important and sometimes underplayed. It's much easier to suture a bladder with a clean cut than going back and fixing a BVF. Spend time on this step. This is an important step, and this is the step where most of the bleeding occurs. The colpotomy. Now, finding the vaginal fornixes can be difficult, but there are ways of finding it. You can put in a hole manipulator without the Christmas tree, or just the Christmas tree bit, but make sure that it is obviously not a placenta praevia that's sitting completely over the os, because then you should avoid using that. But if it's an anterior placenta only, then you can use a Christmas tree with a hole manipulator. You can identify the fornixes, or you can use any cup that can fit around there. But sometimes the best all that to use is a Brusky retractor. A Brusky is just basically like a long Vacuum retractor, but narrower and longer. So when you do the colpotomy, you obviously have to take your uterine and your vaginal artery bundles, and then as you open the vaginal edge, that's also where bleeding can. Just clamp the vaginal edge as you go along. Try and stay clear from cochlears, because they tear the tissue. Rather use long Alice clamps to control the bleeding around the vaginal edges. This is just a nice picture to show the Brusky retractor, where you can look and find your vaginal fornixes. So obviously you won't be able to put a Christmas tree with a whole manipulator cup in there, but a Brusky retractor will just do the job beautifully. So what about internal iliac balloon placements?
Renardo, can I just ask a question just before the balloons? We've got a question here. Is a linear stapler any better than a ligature in performing those steps you've just outlined?
So, Peter, that's a good question. My answer to that is the myometrium can be really thick sometimes. And getting a proper seal with the ligature, getting the ligature in there, there's a curved beak on the ligature. So practically, it is difficult. So if you're going to do hysterectomy, just use a linear stapler. It is so much quicker and it's so much less blood loss. So a linear stapler is the way to go, definitely.
Thank you.
You can use ligature, but you'll see it's far easier to use a stapler. Yeah.
Thank you.
Initial studies have not shown to be beneficial, but when you look at the placenta accreta spectrum, especially the increta and the percreta, there's around about a 600 ml less blood loss. So, but the Dublin team has showed, and the Texas, the more you work as an MDT together, and the more that diagnosis and screening improves, the less it becomes beneficial to have all these balloons, because you can only inflate them for at the time of 20 minutes. The placement beforehand is not straightforward. You can perf and tear an artery. There can be ischemia, especially of the smaller and then emboli. And this was in 2 trials that were shown that with internal iliac balloons and aortic balloons, cases of emboli were identified. So the surgical ligation of internal iliac artery should happen during step 3. And step 3 is where you start going to your paravesical space. It's before you go and reflect your bladder. So by the time that you actually do your bladder reflection, you have bleeding, and now you want to go back in your internal iliac vessels, you've probably almost lost the time. And you really want to ligate it 3 to 5 centimeters distal. So what some groups are doing, a nice report as well, is that they put a go around with a suture hanging loose on both internal iliacs. And then if it's needed, you can tie them. But again, with a percreta and an increta, there are so many anastomoses, and sometimes coming even off the external iliac artery. And then you don't have that benefit of the internal iliac arteries being ligated. And really, they say it doesn't matter what you have, the effect only lasts about 20 minutes. If I may, this is just a little video just to how to tie the internal iliac arteries.
Mobilize a portion of the internal iliac artery away from the adjacent structures in order to safely pass a ligature around it. Repeatedly identifying the anatomy is helpful in maintaining orientation and avoidance during this step. Once again, a Lour is helpful in accomplishing this. Here, some of the vessels from the anterior division of the internal iliac artery can be visualized. Utmost care is required when dissecting underneath the internal iliac to avoid damaging the internal iliac vein. The ureter can be observed vermiculating safely away from the operative field. The vessel is then grasped and elevated with a Russian forceps while a Lour frees the vessel from the underlying structures. This is performed in a lateral to medial fashion to avoid injury to the adjacent external iliac vein. A non-absorbable suture is then passed around the artery and tied 3 centimeters from the bifurcation of the common iliac artery. This is to ensure that the posterior division of the internal iliac artery is not compromised during the process. A second free tie can be placed distal to the initial ligature to help avoid recanalization. In this case, the obliterated umbilical artery is spared due to anatomical variation in this vascular network.
So what about percutaneous aortic balloon placements? In some centers, they've showed up to 1,500 ml less blood loss. Studies show different results. They are definitely better compared to your internal iliac balloons. But the Texas group, with their study, have shown with meticulous 5-step surgery, the blood loss is less than 2,000 mils. Therefore, they negate the need for infrarenal catheter. And this is what's called the Reboa catheter. This is what the catheter looks like, and it's normally placed by either a vascular surgeon or an interventional radiologist. So the Chinese group has come up with a very nice technique of closing the uterus. And I first read about this long, it was time when I was still at SHO in the UK. It was published in the British Journal, and they did studies, and there's now a study that was published about this in 2023. Just for a placenta previa, if you have an anterior placenta previa or a posterior placenta previa, they call a Clovis suturing technique. And with a Clovis technique, they basically start off with placing either a vicryl or a PDS. They start in the lower segment and they work their way around the lower segment first and then higher up into this bulge. The initial studies about hysteroscopic evaluation of now you're compressing the anterior and the posterior uterine walls and the cervix all together. So what about Asherman's, patency, and all of that? And the initial trials of only about 25 patients, they showed with hysteroscopy there was not one adhesion or Asherman's. They've got quite good results there with bleeding. And then they combine this Clovis suturing technique with a upper uterine artery ligation. In other words, as the uterine artery comes up here, they just put sutures right through there, ligating the of the uterine artery that starts running lateral up towards the uterus. So if there's continued uterus, usually it comes from a vascular plexus. There are multiple sutures that are being thrown then. And if bleeding starts becoming out of control, then normally coagulopathy is a big problem. And then instead of, once your uterus is out and you struggle to get the bleeding under control and the blood starts looking like water and it's just oozing everywhere, but it's easily controlled by swabs, speak to your anesthetist, rather pack the patient. If the patient is at a stable point, but you just cannot control it by putting more sutures in, it's probably not the sutures, it's probably the coagulopathy that's not doing its job properly and completely in disarray. So rather pack the patient, correct the coagulopathy, send the patient to ICU, and then correct the coagulopathy, and then do a laparotomy in less than 24 hours. The vascular surgeons at our hospital feel there is a very small place, and even in looking at the literature for interventional radiology in embolizing vessels, in a patient where you struggle to get blood control, where there's a coagulopathy, when the patient is stable and they're still bleeding and you can't get a vessel closed and there's no coagulopathy, speak to your vascular surgeon. But that happens very, very rarely. So what about the conservative management of a placenta accreta spectrum? So here's a team that has looked at leaving the placenta. So just managing it all conservative, not doing a hysterectomy. And they've done a systematic review on this. And our esteemed colleague, Hendrik Lombard, was actually, this is a paper published now in 2025. So you leave the placenta in situ, don't give me, say, these patients receive antibiotics, they'll closely follow up. They want to preserve their fertility. And here's a point where you can excise the part of the increta or the accreta, repair the myometrium like you would do for a myomectomy, and then you can do the above with or without uterine artery ligation. And just a conclusion here, this meta-analysis strengthens the evidence supporting conservative management for pregnancies with placenta accreta spectrum, demonstrating that it is associated with reduced surgical morbidity and may offer an effective alternative to cesarean hysterectomy, and particularly for patients seeking fertility preservation. In this meta-analysis, they include about 116 trials. The trial sizes varied anything from 5 patients to about 30 patients. So, I mean, there's still a lot needs to go into assessing and say if it's safe or not. But I don't think that the patient who wants to preserve a fertility, they all must get a hysterectomy. As long as they understand the risks, especially if it's a accreta, it goes into the pelvic side walls. You know, you must really think twice or 3 times before going to do a hysterectomy and maybe just let things cool down. Unfortunately, there are quite a number of patients that ended up with a hysterectomy. The Chinese group looked at, I think, in their group, they had a conversion rate to hysterectomy in less than 10% of cases, which is remarkable and which is also being noted in this meta-analysis. So I think our time is almost up. So as a summary, diagnosis and high index of suspicion is very important. Have an MDT approach, at least if you're not referring to one. Careful counseling of the patient. The cell saver is your friend. Look at the 5-step approach, especially a bloodless entry and then delivery. And then the bladder dissection part. Do not give oxytocin. And the last but not least, good luck.
Thanks so much, Renardo. Wonderful presentation. Beautiful. We all like to congratulate you on all your work. Oscar Shamangi has just said that he said that if a woman is a Jehovah's Witness, cell savers are kosher. You can use them under those circumstances. That is not contraindicated. So thanks to our sponsors, the Pelvic Floor Foundation, and thanks to Chris and Steve. Final word from you.
Yeah, thanks very much, Renardo. Just very interesting. I mean, you've clearly taken this whole management of these things to a new level. You've certainly turned it into a much safer procedure. You've taken a really very dangerous, life-threatening obstetric condition to something that is manageable in a very controlled environment. And I think, you know, these patients would best be managed in these centers of excellence, you know, and, you know, I think I would encourage everyone to just get your patient to one of these places once you've diagnosed it. You know, I don't think these are well managed outside of a good center, and you can see there's a lot that goes into it, but if you've got your system in place, to take something that is life-threatening to something that is very manageable and doable and ends up with a, you know,
Good outcome.
live mum and baby.
Yeah.
So thank you very much.
Thanks, Renardo. Looking forward to seeing
you
you at FIGO. Looking forward to seeing you at FIGO in October. And until then, safe home. And we see all our people over here next week for the presentation next week. Thank you very much indeed. Thanks, Renardo.
Thank you very much.
Thank you.